A very, very warm welcome to you. It's our last Reach Out, Reach All webinar of the year. Feels like it's been a very long year. And of course, this one is a kids, carers and family edition. We are delighted today to be joined by two fantastic paediatric specialists, a dynamic duo that some of you may have seen at our conference. But for those of you who don't know you, Dan, then John, can I please ask you to introduce yourselves? Dan, you first.
Yeah, so my name's Dan Limson. I'm a paediatric neurologist working at the Aberdeen and London Children's Hospital, so by St Thomas's, just in the centre of London. And I'm one of 3 consultants on our complex motor disorder service that delivers DBS to young people in our part of the country.
Fantastic. John?
And I'm Jon Ellenbogen. I'm a neurosurgeon that works in Alder in Liverpool and at the Royal Manchester Children's Hospital in Manchester. And I am a specialist in movement disorder surgery and also epilepsy surgery. But I implant a reasonable number of deep brain stimulators in children in the north of the country.
Fantastic. Thank you. And thank you so much for joining us today. I know that both the people that are joining us live here and people that will be watching this on a webinar are really appreciate you giving your expertise. For either one of you, John and Dan, our first question is, what part does genetics play with dystonia? Who'd like to take it?
Go on, Dan, you start.
So I think genetics is a hugely important part of it. And so if we think very broadly, if we're talking about the causes of dystonia, we have a large group of people for whom there is a genetic cause, and often they're young people for whom there are no other abnormalities in terms of their examination other than the dystonia. They have an MRI scan that looks essentially normal, and it's not the structure of the brain that's abnormal, it's the function there. And that's to be compared to young people for whom we see probably as the majority of certainly my practice, where the dystonia is as a consequence of an injury to an otherwise normal brain. And this would be the young people we'd say who have cerebral palsy, or if the injuries happened a little bit later, if they're developed, then it's an acquired brain injury. So I think it's very important in terms of why something's happened, as to whether there is a risk that other family members might be affected, other children in particular, and in terms of choosing and considering and counselling for our neurosurgical indications there. So we know that some of these genetic causes for dystonia, so the DYT1 dystonia, the DYT11, they're very likely to have a very positive sustained response to deep brain stimulation, and they're young people who we would want to move forward for the program quite quickly. There are some causes where we know we'll get some response, but possibly less than that. So the KMT2Bs and some of the more recently described conditions. And then there's some conditions where we're still finding our feet about it, or perhaps some indications that they might not do quite so well there. So I think genetics is very important for why something's happened, what might happen in the future, and of course, how we might treat that.
Okay, brilliant. And John, do you see people with more genetic causes of dystonia or other causes?
So I see a mix of patients, but the majority are those patients that have or develop dystonia from secondary reasons. So as Dan was saying, not so many of the genetic varieties of dystonia, but more because children have had insults early in life, such as cerebral palsy, or had a brain injury early in life and developed dystonia. So the majority of children that I see are in that other category, that secondary category, and we have to be a bit more circumspect about the results of deep brain stimulation in those patients. As Dan was saying, the genetic dystonias, we can be more certain of a positive result from deep brain stimulation, and in those secondary dystonias, these dystonias caused by other conditions that happen early in life, we have to be a bit more circumspect about whether we can, what the improvement is likely to be.
Just, I'm sure everybody on the webinar knows, but perhaps for people that are watching at a later date, can you explain what DBS, deep brain stimulation, actually involves?
So deep brain stimulation is a way of targeting a very small, tiny area in the brain, which is deep within the brain, and using that area to try and improve and modulate the movements that are abnormal for a patient. So in this case, it's dystonia. And it involves implanting a very fine wire, electrode, into the brain using techniques that mean it gets to the place that we want it to go very accurately. And those wires are one on either side of the brain, and they're tunneled and go through the skull, tunnel under the skin to a battery that sits on the chest or in the tummy, much like a pacemaker might do. And that battery supplies electricity through the wiring into the brain, and we control that very tightly. And hopefully over time, that has the effect of changing and modulating the brain to improve the movement control. But it's a very involved procedure in that we have to be very accurate in the placement of the electrodes, because the target area is about the size of a grain of rice. And so we have to be accurate, submillimetric accuracy when we implant the electrodes to make sure that we get the result that we want.
What does that result look like? What is a good outcome from the surgery for you?
So a good outcome from surgery starts with not having any complications of surgery. But in terms of a good outcome would be an improvement in someone's pain, someone's ability to control their movements or in their cares, being able to feed themselves so that if they weren't able to do that before. But it's very individualized. A lot of these patients will have individualized goals, and we work with the patients to understand what those goals might be and make sure that they are achievable and realistic. Because the last thing I want to do is do a big operation and a patient to say, well, I'm not running round, and I thought I'd be running round. This isn't a panacea. This is a way of helping people to modulate the movement, but it isn't ever going to be a cure for dystonia. It's a way of helping people deal with their dystonia moving forward. But it's very important that that is individualized to each patient. Okay,
and Dan, at what point, just while we'll stay sort of in the world of DBS, just because we've got a lot of questions on it, but at what point would you refer a child over for DBS? Is there things that would come first for you in the department?
So I think this is a really hot topic and something that we as a community need to do some work on, actually. I think part of it comes down to how likely it is someone is to respond. So I think if we've got a young person with one of these genetic conditions we already talked about, where they're likely to get a very positive, very sustained and dramatic response in terms of an improvement in their movement disorder, they're the young people that we would want to see very quickly. And they're the referrals that we really want to encourage. And, you know, there's a list of these genetic disorders that's growing that we're becoming more aware of. For some of them, such as the DYT1 dystonia, it seems that actually the earlier we operate after the onset of the dystonia symptoms, the better the response is and the quicker we get there. So they're young people within our own service that we'd really want to see within, you know, operating within about 6 months of symptom onset if we can there, because we can get those dramatic improvements. After that, when we're talking about a smaller but still potentially very significant improvements, I think we have to balance, well, how many problems is that young person and their family having with their dystonia? And, you know, we want to consider, we don't want this to be the intervention of last resort that you only think of when you've gone through the medicine cabinet and tried everything that you potentially have there. We also want to see those young people where they're having, you know, admissions to hospital with very severe dystonia, where there's risks attached to that. They're young people that we want to see more rapidly there. So it's really that combination of how severe symptoms are. Have they had exacerbations that have been, you know, even potentially life-threatening in some cases? They're fortunately not common, but we do see that there. But hospitalizations, we definitely would want to be a trigger for us to see them there. And then young people for whom that there has been, you know, a number of medications that have tried and failed. But really, we don't want this to be an intervention of last resort. Our colleagues in the epilepsy world would say if 2 medications haven't stopped your seizures, you should be starting to think about other interventions, and that includes surgery. And I would hope that we can arrive perhaps 2, maybe a low number there, but I think we do need to arrive at a number of medications as a trigger for us to be referred young people to consider this.
Okay, brilliant. Thank you. And we'll come back to DBS in just a minute, but you mentioned sort of in the epilepsy world, it's sort of 2 medications or 2 interventions. What other interventions or medications could a young person or a parent of a young person look at? I know obviously there's physical therapy, sorry, and occupational therapy, but what else sits in that world?
Okay, so I think if we're not talking about just moving to one side or putting to one side rather the neurosurgical interventions, we have interventions that are medicines or injections that can help potentially reduce the dystonia. We've got orthotics and physical aids that can help with the consequences of the movement problems. And then obviously we've got therapy, which kind of sits around that and tries to optimize function and improve participation and the like. So if we're thinking about medications, one of the problems we have is that we don't have a really strong evidence base to tell us what the best medications are for any given child or what order we should work through them with. But there are a range of different medications that we can use. Some of them are background medications we're using to try and reduce that tendency to have the involuntary movements. And some of them are medications which we're using as a breakthrough. So when movements get very bad, we take those medications to dampen them down. They're often very sedative. Those medications can be really effective, but they unfortunately often have quite a high side effect profile that limits their use. And we have to balance off what we're gaining by reducing the dystonia with what we're losing from those side effects there. The botulinum intoxin is an injection of a neurotoxin. Sounds very scary when you say it out loud, but it's a very good way to relax muscles that are contracting when they shouldn't. And where that has the real benefit is you can target where you want to relax the muscles. So if it's just one or two muscle groups that are causing lots of the problems, you can treat those muscles with the injection, and it means you don't have those systemic side effects that you get from the oral medications. The downside is that they wear off and you have to repeat the injections. And so you're talking about at least 2, if not 3 a year to have those there. Orthotics, of course, are very individualized to the child there, but it's splints for the ankle, braces for the spine, and it's really about trying to maintain a position, often more difficult when you're dystonic because you're pushing against it. And then a huge part of this all is the therapy input there. And the way I see it is interventions reduce impairment, try to get rid of movements, but it's really the therapist and the input from the therapist that optimizes function and gets the most out of these interventions.
Okay, so we've tried a couple of those, and then in an ideal world being referred to DBS, but that's a scary thought, isn't it? Brain surgery is a scary thought on a child. How, and in fact, this perhaps John, you can answer this one. How would you go about talking to a parent about this as an intervention, as one that works? What are the sort of concerns that come up, and how do you allay them?
Well, I think it's very important that parents or patients have a range of different information and people they can talk to about it. So I'm quite lucky with the department that I work, is that I have a very large team around me, and many patients will maybe see those people before me, so they'll have an idea of what they're coming to speak to me about. So, for example, the physiotherapists that do the assessments to decide how severe their movement disorder is and what their movement disorder is, and they know about DBS and can talk to patients about it. Also, the occupational therapists and the neurologists like Dan will obviously have a chat about to parents and patients about what it is that on offer to them. And a lot of patients will come to me with an understanding of what deep brain stimulation is, from reading it online or visiting your website or various different modalities. But the first thing is really to say to them that it's a relatively safe procedure. Although it's brain surgery, it's done under very controlled conditions. Everything's planned well in advance. And so we do everything we can to minimize the risks for the surgery. And actually, although it is putting something deep into the brain structure itself, the risks of anything going wrong are actually quite small, because it's also well planned and everything is planned to the nth degree, and we need to do it very accurately. So we do minimize the chance of anything going wrong. So I try and put people's minds to rest in that respect. The more difficult thing is trying to explain to people how, even after they go through this, I don't know whether it would work for them or get the results that they would want. Because as we spoke earlier, every patient has to have individual goals, and it's very variable, the results that we can get from deep brain stimulation. And not only that, it sometimes can take some time to see any results. So it can take a year or sometimes more to get any positive results from the stimulation, because it relies on lots of different changes happening within the brain and neurotransmitters to get a result. You don't get the immediate effect, the sort of nice photographic evidence that you see with Parkinson's disease, for example, when a deep brain stimulator goes in and you see the tremor go immediately as soon as the switch is on. With dystonia, it's much more a long-term process that we're relying on this changing the brain milieu, as it were, over a period of time. And there aren't any validated criteria to say this child will do well and this child will not do well. And there's no real hard and fast rules about which children will do better than others in dystonia, other than genetic dystonias tend to do better. So it can be quite difficult, but the thing I think is very important is to give as much information as you can and give parents and patients time to understand what you've said to them and bring them back and have another discussion with them about it, because there is so much information to take in and it can't be taken in all in one go. And it's about having the time to make the right decision, because it isn't right for everybody. And I think it's really important that the parents and patients really understand and really want to go forward for the surgery, because it isn't right for everyone.
And I think just to add to that, I think an important thing is it might not be right now. And just because something's not right for the family at that point, circumstances might mean that it's not the right time for an intervention there. Things can change in the future, and it's all right to come back to this there. And I think for a number of the families that we work with who've ultimately gone ahead with surgery, it's taken a while for them to feel it's the right decision. And that's a hugely important thing. The last thing that we would want to do is for anyone to be rushed. And I think if you do feel rushed into any of these decisions, even if you get a good outcome, I think you're always going to have not had the best of experiences with that there. And I think it's absolutely fine to take time. It's absolutely time to revisit that. And I would hope that all of our teams who are delivering these interventions are open to that and allow children and families that time to come around to that decision if it's right for them.
And is DBS offered to many children is one of the questions that we've got for you.
Well, it's okay. So the problem is that those people that come into our service who are suitable candidates will get offered DBS. The problem that we have, I think, particularly in the UK, and Dan might agree, is that not many clinicians understand that we can use DBS for patients with dystonia in the first instance, and not many clinicians also understand movement disorders. They're quite a complex group of conditions, and in children it's even more so, because GPs, even pediatricians, don't have the experience of diagnosing movement disorders and the types of movements, so they find it very difficult to differentiate spasticity from dystonia, and therefore they may not be on the right therapies or be pushed down the right treatment modalities, because they're diagnosed either with not diagnosed with a movement disorder or diagnosed with the wrong movement disorder. And so I think in the UK there's a very large and tapped population who would benefit from referral to a specialist movement disorder department for consideration of various therapies that aren't getting to those clinicians, and then therefore are not offered DBS. So for the patients, so it's a long-winded way of saying the patients that are in a movement disorder service who are suitable for deep brain stimulation will inevitably get it offered to them, but there's a large number of people in the UK who might be suitable who don't know they are. I don't know, Dan, what was your thoughts on that?
Oh, I couldn't have put it better myself there. And I think one of the challenges for us is we don't know how many young people there are out there, because of these difficulties with diagnosis, because of these inappropriate clinical labels. We don't have a good resource we can go to that tells us, there are this number of young people and this is how we need to develop our services. And so this is why it's important for events like this where we can talk around it. If we think about cerebral palsy, we talked about that as being the most common cause of dystonia in childhood. So there are labels and terms that people use to describe cerebral palsy. It affects about 2 to 3 in 1,000 live births in the Western world. And traditionally, people have said that 85% of young people with cerebral palsy have what's been termed a spastic cerebral palsy. But what we realize now is that actually the majority of those young people who have spastic cerebral palsy actually have a mixture of cerebral palsy and dystonia. And it's often the dystonia which is the more problematic and intrusive movement problem. But because they've had this label, people have said it's spastic cerebral palsy, nobody thinks to put them forward or refer refer them for these kind of interventions or these kind of considerations. So I think there's a lot of young people out there who could benefit from being assessed. And actually, even if they don't go on to go and have the surgery, I would hope that that process of assessment, that being reviewed by people who've got an expertise and an enthusiasm for the topic, will give benefits in terms of recommendations for medications, for therapy, for orthotics, and all of these other things we've talked about.
So would you both recommend for people who haven't had DBS mentioned to them by their sort of primary care team, would you suggest if they happen to be watching this webinar that they bring it up to them and ask if it's something that they can look into, so they take they take it and actually can do something with the advice?
Yes, certainly. I think that if a child or a patient's got a movement disorder and they are not sure what it is, or haven't been offered various therapies, the best way to do is to go to the GP and say, I read about this, what do you think about this for me? And if the GP doesn't know, they should be referring them on to their local pediatrician or neurologist or pediatric neurologist, and getting them to assess, and then they will make the referrals on to the regional movement disorder service for further assessment if they don't think it's necessary.
Thank you. And referrals, are referrals currently being impacted by COVID, have you found? Is that playing a part at all?
Go on, Dan, do you want to?
So I think there has been a COVID effect. I think we have to be honest around that there. I know still quite a lot of our activity is virtual, rather than face-to-face appointments.
Mm-hmm.
And I think we have seen that there has been a downturn in referrals to the service, which is picking up now. And I think that is really very positive there. But,
Right.
you know, we have to acknowledge that there are some waiting lists for us now. There are some backlogs. So, you know, whilst we've said before, there's not absolute golden rules that we know how to predict who's going to be a good candidate for interventions like DBS. We do know there's some things that make a positive outcome less favorable. So the extent of changes on MRI scans, some of our neurophysiology tests, and they're all things where there's waiting lists that have built up and there's a backlog to clear there. And the fact that for lots of families who are listening to this talk there, I'm sure that their experience was that access to therapists is very dramatically reduced during the COVID, and, you know, particularly during those lockdown periods. And it's improving now, but our therapy colleagues out there in the community are a very rich source of referral, because they're the people that really understand the movement problems that they're seeing.
Yeah. Okay, thank you. Couple of potentially quick questions, and then we'll move on, I think, to some more general questions. John, how long does the DBS procedure take?
So the surgery the surgery itself is about 3 hours.
Okay.
In total. But there's a lot of fiddling around that goes on in theatre to get to that point, because when I implant a DBS, I use a robot to help me, to guide me to the exact place I need to get to. So putting a patient's head into the robot and doing all the registration, etc., takes quite a bit of time. The robot doesn't do the operation, but I've programmed into the robot the trajectory that I want to take, and therefore it allows me to put the electrode in and the required trajectory to the required depth with ultimate precision. So in terms of surgery, it takes about 3 hours, but it takes most of a day in terms of getting it all set up and done.
Brilliant.
But the process to get there takes a long time, in the sense that the assessments, and the consultations with the patient, it can take quite a number of months to get to the point where we're implanting a deep brain stimulator from referral.
And is there a general time limit for that, or is it just, it's so varied you couldn't say?
So what the ideal would be, the ideal is to implant a DBS with as short as the disease duration as possible. We know that the longest the child has DBS, has dystonia, the harder it is for us to get that movement disorder under control. So from a diagnosis of dystonia, we'd like to try and implant the DBS as soon as possible. A few months here or there isn't going to make a difference, but years are. Unfortunately, with COVID, it has thrown a lot of our normal timescales out the window. because of staff illness, not being able to do assessments, not having the therapists, etc. So ideally, it would be a relatively short window at the moment. There's no real time scale until we can get things back online. But I am implanting deep brain stimulators. They're doing 2 this month, so we are getting back to sort of pre-COVID levels slowly.
Fabulous. And you mentioned sort of the 3 hours. Is the patient sedated in theatre for the whole day, and therefore, but just the 3 hours is the actual operation? Am I understanding that correctly?
So at the moment, because of COVID, my workflow has changed slightly, because what I need to have is an MRI, which is relatively up to date, so I can plan where I'm putting the electrodes on the MRI. Mm-hmm. With COVID, because our MRIs were performed and then obviously lots of things shut down, we had quite a long time window between the MRI being performed and the surgery happening, meaning that some patients needed to have another MRI before the operation. So now in my workflow, I do an MRI. The patient gets put to sleep. They have one general anesthetic, but we do everything in that general anesthetic. So the patient has an MRI, I do the planning, they're put into the robot, they have their operation, and then they're woken up. So it is a long day, but the patient won't realize that because they're asleep the whole time.
Yeah.
And it minimizes the number of general anesthetics the patient needs as well.
Good thing. And are there many follow-up appointments for the tuning? You mentioned that sometimes it could take a year to see those outcomes. Is that lots of follow-up appointments in that time?
Yeah, so usually around 6 or 7 in the first year, which is quite a lot. So because what we're trying to do is slowly titrate up the stimulation to a point where we're getting effects, but without side effects. Because at the end of the day, what we're doing is putting electrical signals into the brain to help modulate movement. And if those electrical signals are spreading to areas that we don't want them to go to, then patients might have side effects from the stimulation. And so what we want to do is carefully titrate the stimulation to a level which provides us the best result with the minimum side effects. And that takes quite a bit of time. It sometimes takes a lot longer than 6 appointments, but usually in the first year, it's something like 6 to 7 appointments following DBS. I don't know, Dan, what's your current practice?
Yeah, quite agree. It's around that level there, and part of this is around ensuring that wound healing's happened. We talked about the complications of surgery, and whilst the surgical event is fortunately very safe, particularly when performed by my colleagues, the thing we worry about afterwards is infection. And in our own case series, it's about 8% of children end up with a wound infection, so we have to be very kind of vigilant for that there. I think one of the challenges with dystonia compared to other conditions, as you see on the kind of YouTube channels there with Parkinson's disease and tremor, is that when you make a settings change, you very rarely see a very rapid change or response to that. And so the tendency, or the risk rather, is that you make too big a change trying to see something, and then you end up a few days later finding out that you've overstimulated the young person, and they have to come back down to have the settings kind of reversed or altered there. I think also as well, our experience with dystonia is that for lots of young people, there's not a kind of golden setting where once you hit that setting, that's the absolute best and you never need to change it from there. Sometimes it feels like the dystonia gets under control and then kind of works its way around those settings, and you have to kind of chase it a little bit there. So it's a long process, and that's a really important thing. These are not interventions that are one-off curative procedures. These are a management option, but it's a long-term commitment to the therapy and to reviews by the team.
You mentioned the wound infection and the difficulties fine-tuning the DBS electrodes as potential risks, but what are the risks of the actual procedure, John?
So the risks of the procedure are those with any brain surgery, and bleeding is probably the biggest one, but actually in deep brain stimulation, as Dan has alluded to, it's infection. And we really want to reduce the chance of infection happening, because if infection happens, then either somebody usually needs to have antibiotics for relatively long term, or sometimes intravenous into the veins. And sometimes we actually need to remove the deep brain stimulation, the stimulator part of it, or sometimes all of it, to treat the infection. Because once you've got a foreign body that's infected, it's very difficult for the body itself to fight that infection off. So infection is something we really don't want to have. And 5 days before any of my patients have deep brain stimulators implanted, they get a body wash and antibiotics for the nose to try and rid them of any skin bacteria. And then even after the procedure, they get 3 days of IV antibiotics. So it's sort of something that we take very seriously to try and minimize the risk of infection. But bleeding and infection are probably the biggest risks, but there are other risks. They're the same with any other brain surgery, except the risks are generally a lot smaller. And that is the risk of CSF leak, which is the fluid, the cerebrospinal fluid, which circulates around the brain and spinal cord. Sometimes that can leak out, but that's not usually a big problem. It's a few extra sutures that are required. There is a very small risk of seizure, stroke, and a very, very small risk to life. But those are things that I have to warn people about because it's brain surgery. But I've yet to see that from a deep brain stimulator implantation.
Okay, that's good to know. And the equipment, did it need much maintenance or replacement, or is it you have this operation and then other than the fine tuning, you're done?
So it's very advanced kit, and it's for some very cool kit. So patients get little mobile phones so they can control and see what's going on with their deep brain stimulator. And the batteries that I implant in children are all rechargeable. So they have a very long lifespan of 25 years. So the battery will not need replacing for that length of time. So it's a very good way of trying to do a procedure and minimizing the number of surgical procedures following it. There is a fixed life battery which lasts 3 to 5 years, and therefore you need the battery change after that many years, but that's not what I use, because why put a child through those operations when they don't need to? And to recharge it is very simple. It's like a mobile phone recharger that you just put your phone on and it charges it. It's exactly the same. You have a little disc that sits over the battery wherever it is and charges it through the skin. There's no plugs, there's no plugging in, there's no nothing visible. It just sits over and recharges the battery. And to be honest, most people don't need to do it more than once a week. If they do it half an hour to an hour once a week, that's more than enough. I try and get people to do it daily so they don't forget or get into a routine of doing it. Because if you don't do it and the battery dies, obviously it switches off. But it's a very simple kit to use once it's implanted.
And what is the success rate? Is there a percentage that you look for this operation?
So again, that's very difficult to answer because it's individualized, the outcomes and the goals that we have. So I can't say to you that X number of patients will have X improvement. What I want to do is I want to try and achieve a realistic goal for each patient, and because it's individualized, it's very difficult to put percentages on. I don't know, Dan, how would you?
Yeah, I quite agree. And I think one of the challenges goes back to this idea that there's not one dystonia. So, we've talked about cerebral palsy, we've talked about different genetic causes, but thinking about the cerebral palsy, there's a range of different problems that can have occurred to the brain. There's a range of patterns of injury and severity of that there. And so this, what we term heterogeneity, so this differences across the group, make it very difficult to extrapolate. I think what we're all very keen to do is to share our experience, to try and build up those numbers and say, okay, well, we've operated on this number of children, but there's this number of your condition. And as we kind of cut it down, it becomes quite difficult to give those big numbers or those averages or percentages. And I think as well, as John said, that the outcomes and what we're aiming for is so personalized to young people. And I think a lot of that goal setting is something which evolves certainly in our service over time there. And we're trying to use that experience to give realistic expectations of what we can achieve. And I think where we've got realistic expectations of what we can achieve, we're honest and we can communicate that, and families, that matches what the families are hoping to achieve. I think that's where we're more likely to get the significant responses. And as John said, if we get those goals wrong, we might see as the clinical team that there's been improvements, but if it's not what the family have been hoping for or expecting to see, it won't be an success to them. I think that's one side to this is, it's a success to the child, a success to the family, and a success to the clinical team. And sometimes that doesn't all match up.
It's about managing their expectations, isn't it? So that everybody knows that goal that you're working to.
Yeah. And it's all right if that's not enough for the family. So I think certainly in our experience, there'll be families where we've gone through this assessment process. We felt that actually the young person could gain from the DBS, but actually what we've had to offer when we've kind of put it in black and white and said, this is what we'd be hoping to achieve, that's not been enough for the family, for the risk, for the inconvenience, for this commitment to this lifelong intervention. And that's okay. It's okay. What's not okay is not to have those honest conversations and not to have those honest discussions. But we certainly don't feel that we've wasted our time if we go through that process and it's not right for the family, because we've given them the best opportunity to make an informed decision. And I think that's a really important part of these therapies.
Yeah, it's got to be right for what's going on at the time with their lives as well. We've had a question in the chat from Jade, who has asked, her daughter is 4, hello Jade's daughter, and has pontocerebellar hyperplasia. She's development, I said the first word right and got stuck on development. Somebody say this word for me.
Developmentally.
Thank you. Don't know what
Sorry.
happened there. Delayed. Has constant involuntary movements and is unable to sit and crawl, etc. And their life with her, though hectic, because she's 4, is steady, but dystonia is a big problem for them. And they spent 2 days in hospital last week with her in a dystonic crisis. She's on gabapentin and chloral hydrate daily and has midazolam as a rescue med. How would Jade go about getting a referral for the DBS if she was a candidate?
Go on, Dan. Probably.
Okay, so Jade, I'm very sorry to hear, because that doesn't sound like an easy situation with all those the medications and that treatment. So I think it's obviously very difficult to comment on individual cases when we don't have lots of information. But any young person where we've had hospitalizations for the severity of their dystonia, they're on regular medications as strong as chloral hydrate, is someone I think we would all within our community want to be seen by expert movement disorder teams. So it's making sure that, the GP is obviously referred on to the pediatric services who'll be involved, but then there's a pediatric neurologist that's involved in their care, or someone with real neurodisability expertise. And I think it would be very reasonable for Jade, your daughter, to be referred to a movement disorder expert in the area. So, obviously if it was London, that could be us, it could be John's team up in Alderhay, but it would seem very appropriate for that to be kind of passed through that chain there.
Brilliant. Thank you very much. And Jade, I hope that answers your question. I'm going to come away from DBS a little bit because we've got a lot of questions on some general things. One that comes up quite often, in fact, is, does cannabis oil work with dystonia and the pain that it causes? Dan, would you like to take this one for me?
Hey, so there's been a lot of interest and there's been a lot of focus on cannabis and cannabis oils there. And really, we don't have any robust or good data in the field of dystonia. So we know that for certain forms of epilepsy, so quite rare forms, but we've got good trial evidence that there's benefits to the CBD and the Epidiolex, the preparation that was used for those. And within the NHS, it's possible with those criteria to get the prescriptions for those medications with appropriate expertise. There's much less work's been done focusing on dystonia, though there are some anecdotal cases and some reports of people responding. The largest study in children was the Sativex study, which is a cannabis derivative that was in young people, predominantly actually with spasticity and cerebral palsy, but it also included some young people with dystonia as well. Our centre was one of the centres that was involved in that study, and there was a lot of enthusiasm and hope with it there. But unfortunately, the trial didn't demonstrate any benefits of the drug compared to placebo. And so it's not something which we're routinely prescribing to young people there. Obviously, CBD oils are things which people can very safely and legally buy in the UK. Derivatives like Holland and Barrett there. It's not something which I think any of us are able to prescribe to young people or would be able to guide on dosages there. But I'm always very open to families trying things as long as I know about it. I think it's really important that the medical teams that are involved in children's care are aware of that there, and that we're not changing other medications or doing other things at the same time as an intervention like that started. Because if we start something and something else is going on in the background, if something works, well, we don't know what's worked, and then we can't kind of rationalize afterwards. But equally, if there's been a problem or a side effect, we don't know what's caused that there, and that's, you know, could be two things which are discarded as being potentially risky there. So I think, you know, people need to be informing the medical teams and just making sure we're not changing too many things in one go.
Keeping having those open and honest conversations that you spoke about earlier, isn't it?
Absolutely.
So our next question is, are there any non-medical, non-invasive treatments that are worth trying to help with dystonia in children? And I know you mentioned earlier things like orthotics, but what about, for example, sort of natural supplements or specialist movement suits?
So I think, you know, part of this is around what's the problem the dystonia is causing. So certainly there are many orthotics. There's Lycra, for example, and Lycra is not so good, or it doesn't constrain the child. So you're not wearing Lycra to stop the dystonic movement there. It's often about providing some sensory feedback for children who that's part of the issue, or where there's low tone, it can help supplement that there. Certainly orthotics that can help maintain a position, but the problem with dystonia is you can often push against it, cause rubbing and cause injury there. There is a wide range of therapy interventions that young people can benefit from, and I'll admit there are people who would be better placed to kind of talk about that in a future webinar, I'm sure. One of the things that often comes up, and I think lots of families feedback to me as being really, really beneficial, is massage. Now, I'm not very good at giving massages myself, I have to admit there, but, you know, massaging is very useful for children, particularly when there's dystonic pain there. It's safe. It's not something where there's a side effect from the medication there. And actually, it's a really lovely experience for the family to have that kind of physical connection to each other, and, you know, the family to be able to do that and have that time together. So that's certainly something, particularly where there's painful dystonia, that lots of families have fed back to me that their child and them have had benefit from. And I think that's an important thing to explore.
Brilliant, thank you. And is there any evidence to suggest that a blended diet, i.e. real foods as opposed to synthetic meals, can help children with dystonia who are tube fed?
So this is a really, really interesting topic. I could go on about this for a long time, but I'll try and keep it concise there. So the bottom line is there's a growing body of expert opinion and hopefully evidence that's accumulating that there's very real benefits to the blended diet. So we are increasingly aware that a lot of problems with dystonia and a lot of problems with pain and discomfort in children we see come from the gut. And, you know, the human body is not designed to live on an odd milk feed only, you know, into the teens and beyond there. So there's lots of benefits from having the anecdotally and from what other colleagues have reported there of the blended diet. Colleagues in Glasgow are leading some work around trying to define some standards and get some agreement around this there. And they've actually observed that since they've switched to using a blended diet, their rates of interventions like jejunal feeding, so when the tube is not just put into the stomach, but passes down into further down into the small intestine, or other interventions where they do more complex surgeries, have decreased quite a bit there. So I think there's very definitely benefits to be gained, and I think it's something which we would want to be very supportive of. And yeah, anecdotally, lots of families that I look after have really felt a benefit. You know, reduces reflux, probably gives you a much better sensation of fullness. It's a much more kind of normalized diet there. It can help with constipation, and there are all of these benefits to it.
Brilliant, thank you. That's so great.
I'm quite an enthusiast about the blended diet. Sorry.
I saw that. No, it's fine. What advice would both of you give to a parent or a teenager that is at some point or soon going to transition into adult services? Because that can be quite a jarring transition for people.
Yeah. I mean, it is a scary transition for anybody, really, because child services are, for a better word, a bit more cuddly than adult services. There's more support generally for children than there is for adults, and it can be quite a scary thing moving from a nice and cozy children's hospital to a big and scary adult hospital. But that what people have to be aware of is that exactly the same services exist in the adult world as the pediatric services. So in the pediatric world, so there are huge deep brain stimulator teams in the adult world that deal with Parkinson's disease and dystonia, so there are the range of professionals out there that can manage and do manage patients like them. I think the key to it is trying to have a good relationship with your adult transition hospital, because they'll be transitioning to probably a more local hospital to them, and sometimes having joint appointments when they first are considering that transition with the adult and the pediatric teams together in one room, so you can understand how it will work and move forward with their care. But it's not an easy thing to do, and it can be quite scary, and it's not something that you just jump into. It's a staged process that you make the patient or parent aware that it will happen at some point, and then it does happen eventually. It's not something one day you're a child and the next day you're an adult in an adult hospital.
And I think, yeah, absolutely. And I think talk about it early. You know, transition should be this process. It's not a baton pass where, you know, you go in the clinic door, a pediatric patient, and you leave the room an adult patient. That's not at all how it should work there. And, you know, going back again, this idea that there's lots of different causes of dystonia. And whilst there's it's in the adult clinics that are interventions like the DBS and our medications, it may well be that actually the condition your child has is very uncommon in the adult population. And so being aware of that and accepting that they may not have a lot of experience of that particular condition, but it doesn't mean in any way that they're inexpert or not good at their jobs there, but thinking about, you know, how we can make sure that those teams have got their understanding. I think one of the things we have challenges around is there's not a direct match between children's services and adult services in terms of what perhaps the individual clinicians do. So as a pediatric neurologist, I may be managing, you know, the DBS for that small number of children we see with the DBS, the dystonia management and their epilepsy. You may need to kind of find a number of other clinicians to manage that in the adult setting. And it may be that that's in different sort of physical environments. But I think it's a process, engaging with it early on, having honest discussions about what your concerns are with the medical team and the nursing team and the therapists as well. And, you know, these are all things that all of our patients hopefully go through. But it can be daunting. And I think it's really important that we all acknowledge that.
Brilliant. I mean, great answers. Thank you so much. I know that, John, you need to leave on time, but I just have one more question from the chat, which goes back to actually the diet question. So perhaps Daniel, the press person, to answer this. They're asking, Joanne, I believe, is what about the keto diet?
Okay, so the ketogenic diet is this low carbohydrate diet, which is high in protein and it's high in fat there. The ketones are the substance the body produces when it doesn't have enough sugar on board, and they're an alternative fuel source there. There's a great deal of evidence for the use of the ketogenic diet for seizure control. And this goes way back to kind of ancient times where people would realize that when there was times of fasting, some young people with epilepsy and some adults with epilepsy would see a reduction in their seizures. So we know that the ketogenic diet is very good for epilepsy. And again, going back to this idea of if two medications haven't controlled your epilepsy, the ketogenic diet is one of those other options that could be considered, as well as things like surgery, you know, on that case-by-case basis. Unfortunately for the dystonia, there doesn't really seem to be any benefits to the ketogenic diet. There are some rare conditions where it does, when there are metabolic conditions where there's problems with how the body transports glucose from the blood into the brain through that, what we call the blood-brain barrier, but they're very few and far between. There's not very many young people who have that condition. And normally, because it's so effective for those very rare genetic conditions there, it would be offered as a kind of standard of care. So great for seizures, but apart from these really rare conditions, not very useful for dystonia, I'm afraid.
John, Dan, from everyone on the call tonight, and from, I'm sure, people watching for the foreseeable webinar, thank you so very, very much.
You're welcome. You're welcome.
Always a pleasure. Thanks, guys. And Merry Christmas if you're watching this before Christmas.
Happy New Year.
All the holidays.
Yeah.